Australia's Indigenous population consists of Aboriginal and Torres Strait Islander people who have lived in Australia for over 50,000 years. New South Wales has the largest Indigenous Australian population. These communities share unique beliefs which interplay in their health perceptions. Health is viewed as not just the physical well-being of an individual, but refers to the social, emotional, or cultural well-being of the whole community. However, the Western health definition is less holistic, which, amongst other factors, has resulted in key issues towards Indigenous Australian health outcomes. This video will focus on the health needs of Indigenous Australians in New South Wales, and strategies that can be implemented to improve their health, which will later be compared to that of a culturally and linguistically diverse population, Vietnamese refugees in New South Wales. Indigenous Australian health needs are influenced by various social determinants. Social determinants refer to the conditions in which people are born, grow, work, live, and age, along with the economic, political, and social systems influencing them. 39% of the disparity in health needs between Indigenous and non-Indigenous Australians is accounted for by social determinants. In particular, the reasoning behind current Indigenous health outcomes is inextricably linked with the political system created in Australia after colonisation. This greatly differed from the existing Indigenous Australian system, which focuses on traditional laws, rules which define how they understand themselves, land, connecting them to their responsibilities over earth as custodians, law, the stories connecting them, and language. Colonisation occurred under the legal term terra nullius, claiming that Australia belonged to no one, thereby undermining the strong connection of Indigenous Australians with the land. This greatly affected their identity, having detrimental repercussions on their emotional and spiritual health needs. Furthermore, colonisation introduced many new diseases to the Indigenous population, including smallpox, measles, and influenza, thereby adversely impacting their health needs. The effect of this resonates today, where in New South Wales during 2011, Indigenous children under 5 years were 1.6 times more likely to be hospitalised for an infectious disease than non-Indigenous counterparts.
Furthermore, European legislations enforced and encourage institutionalized discrimination, as seen in Section 127. Examples of this include the forcible removal of Indigenous people from their land into reserves emissions, and of children from their families during the Stolen Generation. Indigenous Australians were consequently exposed to abusive environments, resulting in the transmission of transgenerational trauma as well as intergenerational poverty from poor nutrition, a lack of healthcare and education. Specifically, this education disparity was seen within New South Wales in 2019, where 23% less Indigenous Australians completed Year 12 education than the general population. Transgenerational trauma furthermore creates an increased vulnerability to future and social environmental stresses, ultimately predisposing individuals to diseases. Research in the field of trauma demonstrates a link between traumatic experiences and psychological and physical health needs. This often manifests as substance abuse, interpersonal violence, physical illness, and criminality. Evidence of this exists in New South Wales, where Indigenous imprisonment rate is 13.5 times higher than for non-Indigenous Australians. Moreover, in the years 2016 to 17, within New South Wales, 19.5% more Indigenous Australians smoke daily. Smoking is the most preventable cause of ill health and death in Australia, linked to many chronic conditions including cancer, cardiovascular diseases, and type 2 diabetes. Approximately 70% of the health gap between Indigenous and non-Indigenous Australians is accounted for by non-communicable chronic diseases, where CVD is a prime contributor, hence is a major Indigenous Australian health need. Each of these chronic conditions decrease life expectancies. Thus, this depicts how the psychosocial history of Indigenous Australians functions as the main reasoning behind Indigenous Australian health needs.
The experiences that Indigenous Australians have when using the Australian healthcare system are a major contributor to their decreased life expectancy. 7 to 9 years is the estimated gap in life expectancy between Indigenous and non-Indigenous people in New South Wales. Many factors contribute to these poor health experiences, including the repercussions of institutionalised racism that occurred post-colonisation. As mentioned earlier, traumatic experiences, such as those from the Stolen Generation, are still acutely felt by Indigenous Australians today. A result of this systemic social exclusion is apprehension, anger, and mistrust of healthcare services. This facilitates poor experiences in accessing health services, since cultural acceptability is a factor that governs healthcare access. Additionally, this apprehensive attitude is further due to Indigenous Australians experiencing barriers in clinical settings, such as a lack of Indigenous staff, feeling misunderstood, and having to use a system tailored to white Australian health needs. Indigenous Australians generally have a more positive experience and therefore better health outcomes when health services are designed to levels that satisfy both their physical and cultural needs. Receiving treatment from an Indigenous Australian health practitioner greatly improves the overall experience for Indigenous Australian patients. In 2013 to 14, the rate of GP services in New South Wales claimed via Medicare by Indigenous Australians was higher than that in any other Australian state, revealing a better health experience overall. Despite this, Indigenous Australians still experience unequal access to medical services and procedures, even though they are subject to higher hospitalisation and disease rates. This experience is evident in Indigenous Australian hospitalisation rates for palliative care in New South Wales from 2013 to 15, where rates were nearly twice as high when compared to non-Indigenous Australians. Further, Indigenous Australians in New South Wales experienced death rates from chronic disease and cancer comparatively higher to non-Indigenous Australians during 2011 to 15. As previously mentioned, Indigenous Australians have a deep spiritual connection with the land they live on. A large component of their faith involves adhering to these ancient beliefs and customs, such as the notion that the land is our food, our culture, our spirit, and our identity. These beliefs are often at odds with traditional Western medicine, which focuses on biomedical approaches to disease management as opposed to a more community-dedicated approach, which is a key part of Indigenous culture. Therefore, Indigenous Australians subject to this approach undergo a less culturally accepting experience in healthcare settings. This lack of cultural sensitivity experienced by Indigenous Australians in clinical settings also stems from a severe breakdown in communication, with many Indigenous Australians speaking English as a second or third language, and many healthcare professionals not being proficient in Australian tongues. Therefore, there are many reasons why Indigenous Australians have negative experiences when accessing the Australian healthcare system. The lasting effects of institutionalised racism, a severe lack of access to Indigenous healthcare practitioners, language barriers, and lacking cultural understanding are all social determinants that contribute to these negative experiences.
Interdisciplinary healthcare needs to address these issues mentioned.
The following interdisciplinary team discussion will highlight strategies that can be implemented by allied health professionals in Indigenous healthcare delivery. A hypothetical cardiovascular disease scenario will be discussed, thereby representing a common health need in the Indigenous Australian community.
Today we'll be discussing Jim, a 54-year-old Indigenous man with ischemic heart disease. Tom, can you please describe Jim's initial presentation?
Jim was experiencing extensive substernal pain, and upon assessment we determined that he was not having a heart attack as he feared. However, we decided that he was in need of treatment at the hospital. We noticed that he was apprehensive to leave, so we asked him if he preferred to take his family along for the ride, since family and community are vital in Indigenous wellbeing. He seemed extremely relieved by this and made this decision with his family. Allowing them to make this decision was essential, since more participation by communities in their own healthcare decisions overall improves their health outcomes.
As another strategy, since Indigenous Australians as a population are a population with a higher risk of poor health literacy, I collaborated with Tom's paramedic team in ensuring the adequate delivery of healthcare education. This was done through providing relevant Indigenous-friendly brochures and videos. How did you go addressing Jim's needs at the hospital?
Upon seeing Jim at the hospital, I was sensitive to the inherent mistrust him and his family may have towards hospitals. Sterile hospital environments can resurface memories of mistrust for many Indigenous Australians, while some consider hospitals the place you go to die. Hence, prior to seeing Jim, I arranged for an Aboriginal health officer to consult with Jim and his family. I carried out this strategy because qualitative data has demonstrated that Indigenous people feel more comfortable speaking to an Aboriginal health officer prior to a non-Aboriginal. This seemed to have made Jim and his family open up to me considerably.
Jim was telling me that he enjoyed those videos, Rachel. This made him more compliant with us. As an at-home based physio, I've been working with Israa and Jim's cardiac rehab program. This is important as Indigenous Australians with heart disease are less likely to receive cardiac rehab. We put together a team of 2 Indigenous health workers to assist Jim in demonstrating some of the activities and explaining its significance from an Aboriginal perspective.
Jim and his family also enjoyed that we talked to them about some of our own cultural health beliefs. This helped establish rapport with them, which has been revealed to overcome barriers such as fear and helps build trust. Jim also felt very motivated after revealing that we conduct a local cardio gym program for Aboriginal men. This strategy takes into account the importance of community kinship in Indigenous health. Rachel, what strategies do you intend on using?
So I intend to conduct a workplace assessment to create strategies Jim can use to eliminate unnecessary stress on his heart at his workplace. I'd also be interested in providing some heart disease education to Jim and his family, perhaps in some kind of community event capacity, since community engagement seems to produce the best results in regards to Indigenous healthcare experiences. To further address health literacy, I intend to collaborate with Aboriginal health officers in delivering engaging, culturally appropriate, community-based education events in Jim's neighbourhood.
These strategies used for Jim can easily be modified to suit the health needs of other Indigenous patients in New South Wales, And, like this cultural group, Vietnamese refugees in New South Wales also have differing health needs to the general New South Wales population.
Vietnamese refugees in New South Wales have both similar and contrasting health needs and experience to those of Indigenous Australians aforementioned. Traditional Vietnamese health belief holds similarities with Indigenous health perception regarding community well-being. That is, Vietnamese culture is strongly oriented with a focus on family and group. Therefore, one individual's well-being impacts the rest of the community. In addition, like Indigenous Australians, the distinct health needs of New South Wales Vietnamese refugees are influenced by social determinants such as unemployment and poor English skills. There was an influx of Vietnamese refugees within Australia in 1976 following the end of the Vietnam War. Since over half the Vietnamese population were displaced in these years, the Vietnamese population were not forcibly removed from the country, contrasting to how Indigenous Australians were forcibly removed from land. However, the immigration of Vietnamese refugees to Australia in fear of the new communist regime paralleled with the new political system that was introduced post-colonisation, which Indigenous Australians were forced to adapt to. After the removal of the White Australia policy, settlement policies accepted refugees, thereby benefiting Vietnamese immigrants. This differs from Indigenous Australians' experiences where existing policies were disregarding of Indigenous communities. Despite government attempts to disperse the refugees throughout Australia, Vietnamese refugees lived in clusters throughout New South Wales, mirroring the traditional community-centred health belief similar to that of Indigenous Australians. In New South Wales, for Vietnamese refugees, research has revealed that refugees exposed to 3 or more traumatic events have a heightened risk of mental illness. This is evident in research revealing a gradual increase in the risk of mental disorder per age group in New South Wales Vietnamese refugees. This trend can be attributed to the older refugees having had to endure more war-related incidents, and furthermore, the trauma from traveling on the boats. On these boats, there was overcrowding, disease, starvation, and pirate attacks, with many perishing at sea. These conditions resemble those experienced by Indigenous Australians within the abusive environments of reserve and missions. The impact of trauma on Vietnamese health needs is further reflected in studies revealing that Vietnamese refugees have higher levels of depression, anxiety, and post-traumatic stress disorder. A similar statistics were seen in Indigenous Australians during 2014 to 2015 in New South Wales. Furthermore, in a recent New South Wales survey, 30% of Vietnamese men claim to smoke daily, correlating with statistics of Indigenous Australian smokers. And as previously stated, smoking is linked to the development of certain chronic illnesses. Furthermore, several studies reveal a substantially higher incidence of active tuberculosis in Indigenous groups than in non-Indigenous groups, and this trend is also common in the New South Wales Vietnamese population. However, contrasting to Indigenous Australians, Vietnamese refugees in New South Wales have lower mortality rates compared to the general population. Ultimately, there are both many similarities and differences in the health needs of Indigenous Australians and Vietnamese refugees in New South Wales.
As previously discussed, cardiovascular disease remains the number one cause of premature death in Australia's Indigenous population. Therefore, our multidisciplinary allied health team have created the strategy, the Workara Way, aimed at improving Indigenous Australians' access, engagement, and most importantly, continual re-engagement with health services within New South Wales. As inspired by the Close the Gap campaign and current evidence-based practice, the Workara Way is driven by the need for equal participation of Indigenous and non-Indigenous Australians in healthcare strategy implementation. Since clinical health settings remain a major isolating factor for Indigenous Australians, the Workara Way seeks to eliminate the sterility of biomedical approaches to health and champion the importance of community-driven healthcare. A more holistic approach will be focused on, since Indigenous health encapsulates culture, country, language, and law in a way that transcends beyond the individual. Therefore, the Workara Way funds and develops the creation of purpose-built community centres that practice transdisciplinary health with collaboration from Indigenous community elders and leaders at the core of decision-making. The community centres are designed collaboratively with Indigenous communities and occupational therapists specialising in town planning and access. Doing so will develop a space that promotes physical activity, thereby improving community cardiovascular health. While privacy can be arranged if desired by the service user, the space is designed with the intention of breaking down current cultural barriers in healthcare. Community teams are made up of Indigenous community teachers and leaders, Aboriginal health workers, traditional Indigenous medical practitioners, Indigenous artists, alongside allied health, nursing, and medical professionals. Evidence suggests engaging in meaningful occupations chosen by the individual promoted health engagement, positively impacted quality of life, and lowered mortality rates.
It is for this reason why holistic preventative health is at the core of the Work Our Way, with informal health talks, cooking classes, art classes, sporting events, and cultural storytelling facilitated by community leaders and elders. Wherever possible, preference of employment is given to health practitioners who identify as Indigenous Australian, with local Indigenous community leaders serving as part of the recruitment process for all positions. This aligns with evidence that suggests improved health outcomes for Indigenous Australians are more likely to occur for those who access services supported by the provision of Indigenous health workers. Moreover, the Work Our Way aims to develop a free app that can be used by anyone with access to a device, such as a phone, tablet, or laptop. This app will include healthcare videos and daily exercise guides for each age group and gender, physical activity monitors, diet planning ideas, medication reminders, and a 24-hour contact service to access lower-scale health concerns. These will all be created in partnership with Indigenous Australians and will include the information in all the known dialects of Indigenous communities in New South Wales. In doing so, these strategies will ultimately create culturally appropriate healthcare solutions to eliminate the health gap in our Indigenous population within New South Wales.